Thank you. So first of all, I would like to acknowledge that the introduction. Yes, my name is Sally. Sally Chen. I'm the Digital Health Coordinator at both BC Children Hospital Research Institute and Women Health Research Institute. And we help researchers to move their various challenges from, from the lab and to implementation to commercialization. We also host bi-monthly seminar, as you can see here, trying to raise awareness of what is happening in the digital health, community, in the research field, and try to share the knowledge with others. And I will let Beth to introduce herself as well.
Thanks, Sally. Hi, everyone, and welcome. My name's Beth Payne. I'm the manager for digital health research at BCCHR and WHRI. And I will be manning the chat throughout this event. So if you have questions, please feel free to put them in anytime in the chat. And like Sally said, there'll also be a Q&A at the end if you'd like to speak up and ask your question then. Take it away, Sally.
Yeah, thank you, Beth. So, like I said, I'd like to acknowledge that we operate on the ancestral and unceded territory of the Coast Salish people, including the territory of the Musqueam, Squamish, and Tsleil-Waututh Nation. We recognize their ongoing contribution to the health and well-being of the community, and I also want to express my respect and gratitude for the opportunity to live, work, and serve on this land because of them. It is important for us to realize, this is the culture, the right, and the history of Indigenous people as we work towards reconciliation and improving healthcare service for all of us here. Okay, now it is the pleasure to finally introduce our speakers. We will have 3 amazing speakers today, as you can see on the screen. So I will give a brief introduction and then let them to share their slides to give a speak after that. So first speaker will be Michael Coss, who is our Director of Data Governance at our PHSA, focusing on creating and implementing a new framework for data sharing, access, and use. He has worked in public health informatics for over 25 years, spanning chronic diseases, health promotion, and communicable disease, focusing on ways that technology and information management can improve health outcome. Our second speaker is Dr. John Jose Nunez. Dr. Nunez is a clinical research fellow and psychiatrist at both BC Cancer and UBC Mood Disorders. His research interests are applying computational techniques such as artificial intelligence, AI, to help patients with mental illness and cancer. He completed his master's degree in computer science during residency, focusing on applying natural language processing to help cancer patients. His research was recently published in JAMA Network Open and has garnered international media attention as well. Last but not least, Dr. Lovedeep Gondara. Dr. Gondara holds an adjunct appointment at UBC and is also a research scientist with specialization in machine learning and biostatistics at PHSA. His research encompasses several areas within machine learning and biostatistics, also including natural language processing, privacy-preserving machine learning, flexible survival regression models, Bayesian statistics, and integration into the healthcare domain. So without further ado, please join me first in extending a warm welcome to all the speakers. And I'm gonna let you, Michael, to share your screen. Let me stop share. Okay. Thank you, Michael.
Thanks, Sally. Well, hi, everyone. So I will be presenting some information around data governance and machine learning / AI, where that borderline is exactly. I think it's vague, so we just kind of lump them together in this context. So I'll just start by, for those that may not be familiar with PHSA's data governance framework, just to mention at a high level that we have a governance program and framework in place for PHSA, and it is really meant to be an organizational-wide approach to enhancing the use of data. So we see data governance in a facilitating role and an enabling role in terms of getting access to data and making use of the data. Because if data's not being used, then why are we collecting it? So so really, we see our role as to help enable these access and innovations, and to of course make sure that we're aligning with legal and privacy and requirements like that, but to try to figure out how to get past traditional barriers to data. This is all part of a PHSA data governance or data and analytics framework. I won't go through this framework, but just to mention that this is all part of a larger PHSA strategy around data and analytics. And we've developed 10 principles for data governance. And I think the one that probably most applies to the talk today is around the growth and innovation. So we want to make sure that everything we're doing from a governance perspective is really looking seriously at the risks and seeing where there are more tolerance for being able to use data in new and innovative ways. One thing I'll share that's a bit new. So the DARE program at PHSA is the Data Analytics Reporting and Evaluation portfolio. And we've been going through a bit of a updating of our strategic plan. And I just thought I would quote one of the components of the proposed new plan due to its relevance here, and that is to empower the use of generative AI, deep learning, machine learning powered analytics capabilities by prioritizing use case and establishing a governance framework and audit processes to uphold ethical standards. So things like privacy, bias mitigation, compliance with regulations, et cetera. And to implement rigorous validation for the accuracy, safety, and clinical explainability of these models, and engaged clinicians to make sure we have decision validation feedback loops for the ongoing enhancement of these models. So this is kind of fresh off the press in terms of direction. One of the many pieces of the new DARE strategic plan. So I just thought I'd talk to what we've been thinking of in terms of opportunities for data governance around machine learning and AI. So as probably many of you are aware, there's different groups at organizations like PHSA and across the province that are working on different aspects of AI and machine learning. So we have the privacy teams who are focused on the privacy components, legal on their components. The risk management at PHSA is looking at risk, how the PHSA risk management approach applies in the AI space. And so we've been trying to look into what is the data governance role in the AI space, and I've just kind of broken it up into 4 categories here. Not that things don't necessarily align perfectly, but just for thought. So from the data side, we have things like source metadata to make sure that the models have or that we know what we're putting into the models so that they're being used effectively. Accessibility of data to the models, quality to support the data quality itself to make sure that the training data sets are of the highest quality possible, and then making sure the data itself is fit for a particular purpose that the AI or machine learning algorithms are being applied for. In the processes front, we think there's roles in terms of stewardship around the training data sets themselves and the results of those training. In fact, interestingly enough, I just got an email question this morning of who is the steward of the results out of a machine learning algorithm. So people are already starting to think about these kinds of questions, and we're hoping to be able to try to start providing some answers to those. Making sure that the models themselves are fit for purpose. understanding the overall model lifecycle management and where there's important places for standards or standard approaches during that life cycle, and enabling access for evaluation purposes to those models. On the knowledge front, we have things like labeling. So what is the scope of the training data sets that are feeding these models? What methods are being used? What assumptions were made around the development of models? What are the limitations and biases and risks? And that's obviously extremely important when putting these models into a production environment, particularly if they're being used around the direct provision of care. We want to be able to share methods and learnings across PHSA. So really get into those centers of excellence that are already being established at PHSA, and spreading that knowledge around PHSA and giving the organization as a whole a bit of an uplift around the use of and development of the models. And then being able to look at what are the actual benefits and outcomes of the models as well. And to be able to hopefully measure those some of those benefits. And then on the innovation front, we want to make sure that we're continuously in a process of quality improvement. So that's both at the model level to make sure that these models themselves don't just go stale, but also from the standpoint of the organization. So in our clinical activities, for example, or our health improvement networks or our provincial clinical programs, see how AI and machine learning can be used to enable quality improvement within our actual programs themselves. Providing safe spaces for risk taking. So maybe that's safe environments to do some testing, or safe types of projects that maybe don't have as high of impacts, and providing those spaces to people to be able to innovate, as well as developing partnerships with academic and industry partners. I'll just to touch on the issue of metadata and data quality. So metadata is information about data. And it really is critical to the successful use and interpretation of data, both by users and I believe by these algorithms as well. So for example, if we are including things like what are the data elements, how is it collected, information about data quality, things like that, then the models themselves can maybe take advantage of that information and be able to weight that information when they're providing outputs and recommendations. And of course, machine learning depends on quality data. So garbage in, garbage out. So we do want to make sure that we're putting quality data in so that we have quality information out. This slide just speaks a little bit again to what we're looking at from a DARE perspective around advanced analytics, particularly in the AI space, and the pieces around the privacy and data governance are a bit on the right-hand side. So again, these concerns around bias detection, auditing the models themselves, and preventing harm or unintended consequences from the use of those models. So what you all paid for to come here is to specifically to hear about the privacy components. So at the last piece, I'll talk about some privacy specific considerations that we've been mapping out. So I've just kind of put here a rough machine learning AI pipeline to just orient some of the different privacy components to that pipeline. So on the data preparation and the model training and optimization side, we have questions around how is the privacy of the training data sets themselves assured? Is there any personal information that's authorized, or is any personal information, in other words, direct patient information in our case, authorized? So making sure that we actually have the right authorities in place to use data for a particular purpose. And then are there any patient consent considerations around the use of that data in the models? And then on the, again, still on the training and optimization front, but also moving into the validation front, where is the storage of the data? Is it within a secure environment within Canada? We do have laws within BC that do require data to be stored and processed in Canada unless specific reviews have been conducted. So it's not to say that things can't be done outside of Canada, but it does require going through those processes to make sure that those have gone through the appropriate review cycles. And then is the processing occurring in a secure environment in Canada? So many of these tools, when we think of OpenAI or Microsoft's tools, a lot of the processing is actually done on computers in states. And so, we need to understand what processing is being done and if there's any permanent storage of that information, or is it just, used for the purposes of processing, but then is immediately deleted after the processing is finished. And who's going to have access on the back end to that data while it's in those stages of storage or processing. And then moving towards the deployment end of things, does the model itself retain information that could potentially identify patients? As we get into, and I will say I'm not a technical expert on this, so others can speak to more of the details around it. But from what I understand, some of the models some of the very complex models often have to essentially in their parameters and things, they end up basically replicating some of the training data, and it becomes part of the model itself. So if that's happening, we just need to make sure we're understanding the risks around the storage of the model itself, if it is indeed containing that type of information. And could anything about the model or its parameters be considered sensitive? And so if so, how is it secured? And then as moving toward use, so once something's been deployed, where are the prompts when people are prompting the algorithms? Where are those prompts processed? Similar situations where the data is stored. Are the prompts stored longer than the user session? Do they become part of a training set later? So do we have to be aware of any privacy concerns around the storage of those prompts over the long term? And then does anyone review the prompts themselves? So Microsoft just released an update to their, I think it was to their Fabric framework for their new Fabric service, where previously they were retaining data for prompt data for, I think it was 30 days around that, and then doing human reviews, I believe, to look for things like abuse and things like that. So just within the last week or so, they've released an update saying that they will no longer maintain that prompt history outside of an individual organization's tenancy of the Azure platform. So that then gives the privacy folks some extra comfort that that prompt information isn't getting out there as well. And before they did this, we actually had to negotiate with Microsoft to get them to provide us a waiver in our own Azure platforms so that they wouldn't do this with our data. So now they're just making that part of their normal offering. But I wanted to just end by saying that it's not all privacy issues that have to be addressed. We also have the opportunities to use these technologies to really enhance privacy. So one area where many of you have probably heard about is synthetic data. So that's where you have identifiable source data, and you're maybe feeding it information about the analysis parameters that you might be interested in using that data for. That goes through an AI model to produce synthetic data. So it's no longer identifiable data, and you can do more in-depth analysis on that without having any privacy concerns. Another area that we're investigating within DARE is the use of AI to monitor privacy. And this may sound very dystopian because now we're having the systems monitoring us. But in our Panda, our analytics platform, we're looking at developing an AI pipeline to ingest the activity logs of the platform, understand the code that people are developing in, feeding it a risk framework, and having these large language models comb through all of that information, and then generate risk scores where it looks like there might be suspicious behavior in the use of the data, because we obviously can't, from a human standpoint, comb through this massive amount of information. So we are doing a bit of a pilot project at the moment to see if we can use these large language models to actually help us do that. And the idea is that we can open up access to data more if we have ways of identifying when there is some bad behavior. So it gives those that are allowing us to use the data more comfort that we are keeping on top of it. And if we are noticing issues, that we're able to address those issues quickly and be on top of that. So there's definitely some privacy added, I would say, components around AI that I think we always have to keep in mind, that it is a balance, and we have opportunities in both areas. And I think I may have been a couple minutes over time, so I will pass that off to our next speaker.
Thank you so much, Michael. Now the floor is all yours, Dr. Gondara.
Thank you very much. Let me start by sharing the screen. Okay. Can you all see my screen?
No.
Not yet. Okay. How about now?
Yes, perfect. Thank you.
Perfect. Okay. Okay. So thanks, Mike. I am just going to carry on from what Mike has introduced. This is going to be a bit more technical. So quick overview of what I am going to talk about. It is a short talk, as we all know, but I'm going to try to see if I can cover a wide range of topics that are important to this discussion. But we won't have time to go into depth for any of them. So if anyone wants more details, please feel free to get in touch offline later. So we will start with a quick overview on why privacy matters. Why do we even care about privacy in machine learning models? How do we define privacy? Okay, can you see my screen now?
Yes.
Yeah.
Perfect. Okay, let's hope for the best. Okay, and then even though I am calling the presentation, it's a technical overview, I'm going to try to not be too technical and just give a larger picture. But that being said, you will see one equation for sure. So let's start with why privacy matters. So in the current era of large language models, such as the ChatGPT or other that we use, the risk of unintentional data leakage is higher than ever. So as Mike has alluded to, these large language models, they tend to remember the training data instances. And any adversary that has enough technical knowledge can query these models to reveal the training data, like what sensitive data they were trained on. And so let's look at a couple examples. So a large language model trained on users' sensitive data, such as, say, if the training data set has social security numbers, personal health numbers, or anything like that, that type of model can be queried to reveal the sensitive information. Like in this first example, researchers used prompts where the model's goal was to complete the prompt. So they asked the model that, say, my social security number is, they gave it the first 3 digits, and the model replied with completing the social security number. And they tried the similar thing with like credit cards. That worked as well. So this was the earlier research that was done in like 2019. And by machine learning standards, that has gotten quite old. So now we even have more stronger attacks, like this second example, which was a recent exploit that was discovered in all large language models, including ChatGPT that is deployed. So in that exploit, what users were able to do were they were able to give a prompt to the model saying that repeat, say a word such as here we have poem over and over, unlimited number of times. So the model will start doing that, but eventually after repeating poem for say 100, 200 times, it will start spewing up data that has nothing to do with the prompt. And in good chunk of those cases, that was the sensitive training data that the model was trained on. So this attack was called divergence attacks. That is where the model diverges from what we are asking the model to do. So as it is with like the often with the security community, before this paper was published, they did get in touch with the ChatGPT team and they fixed this bug before the paper was published. But other large language models, the open source ones, they still do have this exploit that you can still probably go and try. So these previous examples, they point to the issue where we need to be careful around what data we need, what data we are using to train the models, which often, as Mike has again talked about, in case of Chat GPT, like the generic version that we use, even the prompts that we are using, they become part of the new training data. So we need to be careful what prompts we are using, because often when people are using Chat GPT as either a research assistant or even as a writing assistant, people can copy and paste sensitive unpublished data into the prompt to either ask Chat GPT to write an abstract for them or anything like that. So that data does become part of the training data for next iteration of Chat GPT. So if you're putting in sensitive information, you need to be careful. So now moving on, how do we define privacy in machine learning? Like we have talked about privacy. How do we define privacy? Should we say that any data that I deem private should not be leaked by the machine learning model? But then it is how much leakage is accepted. Because often the definition of what is private can be arbitrary and it can differ from person to person. Because like everything else, we need the data to train the models in the end, and the data will have some sensitive information. So where do we draw that line? Can we quantify the information leakage so we can confidently state that my model only leaks X% of the information that it has seen? Can we do that sort of quantification? And that is where differential privacy comes in. And this is the only equation that I promised that you will see. That even though the equation looks complicated, it conveys a very simple and a provable definition of privacy, which is now widely accepted in computer science community and also in other technical security and cryptographic communities as well. So this equation, what it is saying is, it is saying that if we have two data sets, D and D prime, which can differ on any one record, and we have a model M that we run on both D and D prime, the output of that model, when it runs on both the data sets, only differs by the multiplicative factor of e raised to power epsilon and an additive factor of delta. Where epsilon and delta in this case are called the privacy budget. And intuitively, we can see that the smaller the epsilon, smaller the delta, more similar the outputs would be, making it harder to distinguish if the model was run on D or D prime. And as the data sets can differ in any one record, this provides a good individual level privacy guarantee, because an attacker cannot infer any information about an individual because the data sets can differ on any one record. So this is a guaranteed privacy. And unlike other ad hoc methods of privacy protection, this guarantee stands irrespective of the attacker's ability. And that is right now, if I train my model with differential privacy, I can give my model to the attacker that has the best supercomputer in the world. They won't be able to extract any more information than what I am allowing using my privacy budget of epsilon delta. And this guarantee will hold into the future as well, that even 100 years from now, if my model is trained with differential privacy using epsilon delta privacy budget, my model, even in the future, doesn't matter how advanced computing gets, it will not leak more information. So how do we ensure that privacy in the machine learning models? So of course, we can train our large language models with differential privacy, like the definition that I have just shown. And of course, like with everything else, there are pros and cons of doing that. The pros are that we get provable privacy guarantees. We can bound how much information my model is leaking. The cons with differential privacy are that in differential privacy, we have something called a privacy utility trade-off, which also makes intuitive sense. That is, the tighter the privacy, the lower the utility. That is, the accuracy goes down. So if I want very, very tight privacy, the model will have lower accuracy compared to a non-private model, because of course now the model is trying not to leak any sensitive information. And in order for the model to do that, the model restricts what it's outputting, or the model outputs more noisier output, which leads to reduced accuracy. So this privacy utility trade-off is an active research area in differential privacy. The other option will be training these language models with anonymized data. Say in healthcare, when we have electronic health records, if we can strip those electronic health records with all possible identifiable information, and only what we are left with is the information that we can accept is that it doesn't leak any information about an individual, and we train our language models with that anonymized data, that would be the other way to do it. And that is probably the way where most of the organizations are heading right now, just using anonymized data for training if we want to share our models. If we don't want to share our models, then of course we can train our models with data, with identifiable data, but we have to keep our models locally, like Mike has talked about. The only way we can share the models is either if they're trained with differential privacy, with tight privacy guarantees, or if they are trained on anonymized data that does not leak any sensitive information about an individual. And that's it from my side. So I will stop sharing.
Thank you so much, Lovedeep, and sorry about what happened before. That's something like interesting. Okay, so I will let you, JJ, to share and guarantee this won't happen again. Oh, let me try.
This is showing the privacy utility trade-off. we tried to prevent another Zoom bomber, and I could unmute myself. Excellent. Okay, and then I just need screen share. Sorry.
Okay.
Well, while I'm pulling it up, I will apologize to the audience that sometimes I do have slides with one equation in it, but I don't have it in this presentation, so my presentation will not nearly be as cool as Dr. Gondara's. But
Can you try if you can share your screen again?
still disabled.
You have to make JJ a co-host,
I think, okay.
and then it'll be fine.
Okay, excellent. That should be working, and I hope you all now see my slide. Okay, well, thank you again for inviting me here today. I really do appreciate it as an honor, and a great turnout too. That's quite the audience. So today I'm going to be talking about how we can use NLP to make predictions of potentially things that are really important and potentially helpful for our patients. And I'd like to just...
JJ, you might need to zoom out a little bit. This is too big. Can only see a part of your screen.
Oh, I thought
No, I think I can see the full screen.
Oh, okay, then
Same
it's
here.
maybe just my problem. Okay,
I think
sorry.
I tried to share just the window,
Yeah,
so I
it
don't
looks
know.
all good now. Thank you.
Okay, perfect. So we already did land acknowledgements, but I also just like to acknowledge that we are operating and doing research within a healthcare system that is a colonial one, that has in the past and is currently biased towards our Indigenous patients. And I'm hoping that the tools I'm going to be talking about today can one day, play a very small role in helping create this care more equitable. So just quick disclosures, some of my funding for my fellowship when I've been doing this work was from BC Cancer Foundation, with some of the money coming from Pfizer Canada. I won't be discussing any specific treatment recommendations or anything like that, though, so that's quite mitigated. And I would also like to thank the UBC Institute of Mental Health Marshall Fellowship for also supporting this work. Okay, so I'm going to be starting just kind of going a little bit over what AI is, at least to me, and kind of what's spurred on some of this project. So I think there's like a little hand raise function in Zoom, but who here has been a little spooked by how well ChatGPT or Copilot or any of the other various applications work? So yeah, seeing some hands. And even before that, right? Because we actually started this project years before ChatGPT. But who here has been spooked by how well ads are targeted on the internet? How about that one? And as an example, I always like to go into Gmail and see what it's advertising. Yeah, lots of hats there. So I always like to give the example. And I eventually I should find a newer one, but this was a recent one where Google was trying to sell me a vacuum, and you're like, that's kind of weird. But I recently moved, and so my house still needs a really good vacuum. So just an example. And my overarching kind of idea of my research is, the tech giants are using these really interesting technologies to sell us things, right? Or to do other various things. Children are now using it to cheat on homework and whatnot too. So this is all fine, but why can't we actually harness these technologies to help our patients? And that's really kind of what's behind a lot of this work. So today I'm going to be talking a little bit about kind of what NLP and AI is. This might be a review for many of you in the audience. And I'm going to be talking about how we can use these technologies to predict the survival of patients with cancer, one of my recent projects, as well as identifying which patients would benefit from referral to supportive care resources like a counselor or a psychiatrist, which was another project that we've done recently. And then I'll just talk a little bit about kind of how I see some of the applications of AI in the clinic. And apologies for those of you who have seen me talks before. I usually use the same slides for kind of what all these terms are. But the definition of AI that I like to use is when a computer accomplishes a task without explicit instructions. So most of your interaction with the computer is explicitly programmed. Somebody has programmed it. What I like to use is that if you click the X right now, because you're already tired of hearing me speak, that a programmer has made it so click equals true and position equals whatever, and then exit program. Those are explicit instructions, but if you want to use a computer to interact with the real world, often it's too hard to give it explicit instructions how to do things. The example I like is the U.S. Postal Service, when they wanted to recognize handwritten digits, you couldn't really tell the computer what is a zero, because a lot of them are going to look funky, for example. So instead, we could use machine learning to have an AI teach itself how to accomplish a task. The general idea in supervised machine learning is you're going to give the data, give your model training data that's labeled. This works very similar to how we learn to be physicians, for example. Our attending tells us, yeah, this patient has this, and then we say, okay, and then we see the next patient, so on and so forth. And then eventually the AI is able to build up its understanding of how to accomplish this task. Natural language processing is when AI is used to interact with human language. For example, text. I've always thought the name is kind of funny, but the reason we call it natural language is because if you tell a programmer language, they think like Java or Python and not like English or French. So that's the terminology there. So what do we do in these projects? We were using the initial oncology consultation document. That's the document that the oncologist writes after they first see the patient, to predict a few different outcomes. In the kind of first project that we got out, we were predicting survival of the cancer patient, either at 6 or 36 or 60 months. And more recently, in our paper that just came out, we showed how it could be used to predict which patients will see a counselor or a psychiatrist in the next 12 months. And why are these tasks helpful? Well, individual survival prediction is difficult. We might know that for a certain cancer in a certain stage, let's say 80% of patients will survive, but we don't know who's going to be in that 80% or who's going to be in the 20%. So by doing this individual prediction, we may be able to help our patients. Similarly, it can be hard for oncologists to realize which patients, sitting in front of them should see a counselor, should see a psychiatrist. This is for a variety of reasons. A big one is time constraints. There's a lot to discuss in that first appointment. But another one is that, a lot of patients are quite distressed at their first appointment. And so how do you know, like, which patient is going to feel a bit better in a few days and which is going to have this develop into a full-blown depression? And we wanted to use the initial oncology consultation document because this is a very widespread document. Some prior work had, used things like the genetic samples of the tumor, imaging results from a big scan, so on and so forth. But those things cost money and aren't done at all cancer centers. They're hard to access in a lot of places. But pretty much anybody who's receiving treatment for their cancer is going to have this initial oncology consultation document. So that's why we used it. So the data that we used is a database of about 58,000 patients who received care at BC Cancer between 2011 and 2016. In a sense, one of the biggest in the world, but we are getting better data out there. So I don't know how long that'll be. But an important part of this is as we've been discussing the last two presenters, I think both touched on it, is that you need lots of data, lots of good quality data in order to train AI models to do useful things. So the particular models that we looked at in this work, both of these works, are a bag of words model, which is the kind of traditional way to do NLP, doesn't require neural networks or anything too fancy. Two kind of last generation neural network models, convolutional neural networks, long short-term memory, as well as BERT, which is the kind of version similar to GPT that you use for predictions as opposed to generative AI. So generative AI is, when you want the AI to make something new. But if you want to make a prediction, then often you'll use a model like BERT instead of the GPT-based models. But it's still a large language model. And the big advantage of these neural models is that they're able to understand a more complex understanding of language. I'll give some examples in the next couple slides. But the idea is that instead of just looking at what words are present in a document, which is what bag of words does, instead these models are able to understand a bit more about what words are beside each other, how words affect each other, negations, things like that, and therefore able to understand a much more complex understanding of language. So first we could talk about the survival prediction. So our performance really was quite good. I like to call it a kind of A- student, but the balanced accuracy was 84% for the 5-year survival using the best model, AUC of 0.92. Balanced accuracy is very similar to standard accuracy, but it takes into account what's called class imbalance. So you can imagine that if you had 90% of patients not surviving and you just predict everybody doesn't survive, then you're 90% accurate. So balanced accuracy takes an average of both of the two different predictions that you're making. Similarly, 6-month survival was good, actually slightly better, which you might expect if you're predicting something that's a bit closer in time. And I think this was somewhat impactful work because this was kind of comparable or even better than folks who had done this previously using much more kind of fancy data to input into their models. Again, the things that require these big scans or require the fancy biological sampling and genetic markers that's way above my head. But we were able to show the performance to do this task is actually pretty similar and pretty good. One of the other interesting things was that there was actually similar performance between the neural methods and the traditional bag of words method. And this kind of suggests that it's actually just what words are present that matter more than the particular order of the words. So it's important, of course, to understand kind of how our models are actually making these predictions. So this is an example of how to interpret the simpler bag of words model, where you could do this very simply by just looking at the coefficients of your weights, or your weights, which are the coefficients. So you can see that a lot of words that make a lot of sense are used for these predictions, right? Palliate, so when you use bag of words, it takes words and chops them up. It's called stemming in order to make, so, you know, palliative and palliation is the same word. So palliate is for either of those. That's number one, because if a oncologist writes that they're going to be referring a patient to palliative care, there's often a good chance that that person does have less than a 6-month survival. But you can see other things that were important is types of cancer. The word no kind of makes sense. The more times an oncologist writes no, that actually is probably a good thing for survival, for example. And there's also some other interesting things like Whitehorse. And this might be because if a patient's receiving care up in Whitehorse, then their cancer might not be as advanced as other ones. And so that might be a bit good prognostically. But yeah, I thought this was kind of interesting. So we can also talk about the predicting who will see a psychiatrist or a counselor. The balance accuracy was less, and this is not surprising, right? Because these documents aren't made for mental health. I'm sure if we just had a psychiatrist see every patient, then we could do this prediction very well, but that would defeat the whole purpose because we don't have enough psychiatrists to see every patient. But the performance is still quite good. You know, this is more like a B student. The balance accuracy was pretty much 75% for our best model. And it actually might be even better than this because the data we're using, you know, a previous slide of one of the presenters was garbage in, garbage out. The training data that we're using for this was whether people actually saw a psychiatrist, you know, 5 years ago. So the problem is that many patients that this model thinks should have seen a psychiatrist but didn't, maybe could have actually benefited from seeing a psychiatrist. And so we want to actually investigate some of the outputs of our models to understand if a lot of these, or at least some of the false positives were actually patients that were correctly predicted that they would have benefited from seeing a psychiatrist. And in this prediction, we actually see that the neural network models do perform better than the bag of word models. And this kind of suggests that a more complicated level of understanding of language might be actually useful for these predictions. For example, a really interesting one was the oncologist wrote the patient has, you know, headache, bloating, whatever, and also notices fatigue and low energy, whatever, and also notices some other symptoms. And that every time we wrote and also notices, the model became more and more sure that this patient would actually benefit from mental health resources. And this makes a lot of sense because we know that there's a kind of bi-directional relationship between mental health and physical symptoms that somebody's having through their cancer journey. So that the AI was actually able to train and understand that, which I think is so neat, right? Because we're not telling it that that's a relationship; it just learns it by itself. So I'll wrap up very quick here. One of the things we did for this is we developed a new technique that allows us to understand the topics of the sentences that were used to make the prediction, and we could see quite a few interesting things like a family history of breast cancer or really any maternal-sided cancer seem to be quite indicative that somebody would need social resources. Having lots of side effects, for example, that the person's working. A lot of these make a lot of sense, but are also interesting, you know, to research further, potentially kind of hypothesis generating. And yeah, I often get questions like, how do you think AI is going to be used in the clinic? And one of the things I like to emphasize, especially for a more clinical audience, is the concept of human in the loop. That I don't believe, you know, we're going to be having AI replace clinicians' work, at least not for a very long time. But similarly, how, you know, my car doesn't do this because it's like 20 years old because the residency vehicles, but the cars now, you know, they can do adaptive cruise control, they could park assist. We're having more and more of these AI features help us be able to drive. And similarly, I do think in the clinic, these tools are going to be helping us clinicians be able to do tasks. For instance, whether, you know, help us predict the survival of a patient in front of us, or whether which resources they may benefit from. Yeah. So, you know, the question could be, will it ever operate fully independently, and will we actually have AI, you know, complete medical care? I'm not sure. I think that's probably well in the future, but who really knows? Okay, so thank you all so much for the talk, and I could end it up so we have enough time for questions, but really do appreciate the opportunity.
Thank you
Thanks.
so much.
Thanks, JJ. That was a great way to bring all of the talks together with a practical example of this work in action. There are a couple questions in the chat, so please, anyone else, if you have a question for our speakers, put them in the chat now. We have a few minutes, so I'm going to start with a question for you, Mike. The question is, are there opportunities to use the PHSA data and models for research purposes? And I'm just going to take prerogative to add to that a little bit. I do really appreciate the presentation of the strategy you're coming up with, but I did notice there wasn't mention of research in that. So can you speak to a little bit more of the research role within the work that you're doing and how we can leverage some of that?
Yes, thanks. Good question. Yes, it is actually embedded. I didn't go through my full data governance slide deck, but my full deck very much has research all over it. So pretty much everything that we're doing is intended to support both operational uses, quality improvement, program evaluation, et cetera, as well as research. Yes, absolutely. The infrastructure, the processes, the tools, all of that we're developing we absolutely have research in mind for that. Now, I think it looks like maybe part of the question was around specifically at UBC. So as you know, as we've talked about with the models themselves, there is the question of how risky the model itself is of course going to play a factor in that. But we have a good partnership with UBC and PHSA, and so generally those things are able to be ironed out fairly easily.
Thank you. And then the next question I think could be for any of you, but the question is, can you comment on hallucinations and generative systems and how to trust conclusions if we do not have a strong system to detect and correct hallucinations? Maybe Lovedeep.
I can take a stab at it. So for the hallucinations, these large language models, they are designed to hallucinate. To give you an example, you go to ChatGPT, you type a prompt, write me a story about something fictional that has never happened before. Unless the model can hallucinate, it cannot give you that answer. Similar to the generative imaging models, right? People go to the models and say, okay, draw me a picture of a bear surfing, right? Like that doesn't exist. So the model does need to hallucinate to generate those things. So now, the question being, how do we deal with it? There are systems. So when we are putting these kind of models in production, there is a way, like one of them is RAG. So it is how you augment the generation using a retrieval system. So in that case, what you would do is, so say if you're working in a clinical context, I will create a vector database of hundreds of thousands of clinical related reports of what the chatbot is supposed to reply with. So if you ask now the chatbot a question, it is going to look at those documents and then will give you an appropriate answer. It will be the answer that would be grounded in the truth based on that database that we have just created with those related documents. And then there are other methods as well that we can use to make sure that the answers are more grounded in truth. But if you're just talking about generic large language models, there's no way to stop them to hallucinate. That's what they're designed to do.
Yeah. And so it speaks to understanding the limitations and what those tools were developed to do, and then sometimes the need to create things ourselves that are specific to the medical context and will work for what we actually need. There's a question for JJ that's similar to the following question, and I think this is for also you, Michael. What do you see as the biggest obstacle to deploying models to production in hospitals and medical offices?
Yeah, so I think this could easily have its own hour presentations, but you know, because this stuff is exciting, but also has a lot of things we have to think about. I mean, to kind of follow up onto the last question asked, I think a really important thing for clinicians is to have trust with the model, right? And so part of that's going to be validation, you know, especially external validation, making sure that the model can work on new data and not just regurgitate data that it's already trained on in the past. But I think interpretability is also a really important part, and that's something I've really emphasized in my work. And we're right now starting to develop what the system might look like. You know, initially it's going to be just for trials, of course, and doing it. But part of it's going to be that, you know, if you're getting the model to make a prediction on this document, I want to actually show the clinician what words or phrases are being used for this prediction. And I think this will help the clinician understand, okay, yeah, that makes sense. That makes sense. Or maybe sometimes it'll be like, whoa, why is it using that sentence? That makes no sense. It's completely misunderstanding it. I'm not going to listen to the predictive model in this situation. And so I think something like that may be able to really help clinicians kind of build that familiarity and confidence in these tools that they're using.
And do you think allowing the clinicians to then fine tune and give feedback, if that's possible, builds trust, or is that something that you try to work into your work?
I would really love to see that too, right? To have these models continue to evolve and learn, and based on that, and I'm sure clinicians would love that. You know, it's kind of like telling the medical student what they should do instead, but now you get to tell the AI what to do instead, which is kind of cool.
Yeah. Mike, do you want to add to that?
I think I'm definitely echoing what John Jose said. The validation pieces will be huge. I think there's two other things that come to mind as well. Partially related to your second point was around, you know, in data, we've long talked about data literacy. You know, maybe there needs to be something around AI literacy, and where people really understand you know, the limitations and you know, the keeping a skeptical mind when using them, and then making sure that we have, like, that we're very clear to clinicians, you know, this is what the model was trained on X. We know it has these limitations. You know, these are the types of things for this particular model that you need to keep in mind when you're relying on the use of that model. And then the other piece I would say is, I think just as organizations, we have to get our risk management frameworks to allow a little bit of flexibility. And I do think that at PHSA, at least, there's been a lot of work in the last year or so around a new risk management framework that isn't just so black and white as we don't like risk, where things like innovation, where there's many dimensions that we're looking at risk, and that, you know, we look at innovation as a dimension. Certainly we look at patient safety as a dimension, but how can we then use the different dimensions of risk to maybe get some of these tools into the clinical setting if we can balance those with, you know, the other dimensions in the overarching risk framework. So that move from just, you know, patient safety is everything to, yes, patient safety is, we have a very low risk tolerance for patient safety, but because of these other things that we're doing, you know, maybe gives us some more flexibility to do that, to do more. So
sounds like good things are ahead. Yeah. We've run out of time, so I just wanted to thank all the speakers again for coming, and gonna give a shameless plug. We do have a AI and research working group now at the PHSA that many people here are members of, and this group is still developing in terms of priorities and actions, but the idea is that it will support knowledge brokering and sharing resources and education for the community. So if you have ideas or an interest in this space, feel free to reach out to me, or there's an AI in research at phsa.ca email, and we'd be happy to hear from you. So thanks again, everyone, for coming, and to our speakers. and we'll see you in a couple months.
Thank you so much. Bye, everyone.
Thank you.